Session. I'm Yannis Konstantinidis, surgical oncology from Texas Tech.
I'm Krista Kaups, general trauma and critical care from University of California, San Francisco at Fresno.
And let's start with the first paper. We have four very interesting papers. The first one is called Seldom One and Done, characterizing rates of reoperation with direct-to-implant breast reconstruction after mastectomy. Presenter is Dr. Hammond from Mayo Clinic, Arizona.
Thank you very much for having me here today to present our research here in Maui. Not clicking.
Left click should get you forward.
Yeah, still not clicking. Nope.
If you use the arrows.
Like kicking the tires.
Sure, no problem. Nope, still not clicking.
No worries. Sorry. This is just a test, just to see if you're up for this.
This is a test to see if I was here on time.
There's that. There we go. Okay. You're good, but it is left click to go forward, right click to go back.
Excellent.
We'll reset your time and we'll all be fine. It'll be great.
Yeah, there you go.
It's got the post-lunch kind of apathy.
Exactly. Those wings were really good, by the way. If anyone had the wings.
And did you hear we're going to give extra credit? We'll double your credit for people who are here for an after lunch session on a Saturday on Maui. I didn't say CME credit, but I just said extra credit. So bonus points to all. All right. Did he just walk away with the mouse?
Yeah, I think they're
Okay, we're swapping out.
swapping it out.
All right. As I say, I can only think of one very bad joke, so.
The arrows don't work either.
He's got nothing. He doesn't have he doesn't have a laptop.
Yeah,
So yeah,
For a mouse.
believe me, we would have tried it. Okay, well, it's a few things more awkward than standing here, looking at the audience, ready to go.
I think silence is golden on my part. I can only mess it up at this point.
Fair enough. Are you all right? So we're having a hang up, so just say, please advance slide.
Oh,
It's
sure.
going to be kind of an Alexa thing, but even better.
All right. Again, thank you for the opportunity to come and present our research in Maui. Next slide, please. No disclosures. So more breast cancer patients are actually choosing to pursue reconstruction after mastectomy. Next slide. So in terms of different methods of reconstruction, there's direct to implant, whereby at the time of mastectomy, a permanent prosthesis is placed at the index procedure. Next slide. Also, there is tissue expander reconstruction, whereby a tissue expander is placed at the time of mastectomy and then subsequently exchanged for permanent prosthesis during a subsequent operation. Next slide. And then there's autologous tissue reconstruction, whereby for the sake of this paper, we look at free DIEP and muscle-sparing tram flap reconstruction, which uses an abdominal donor site and utilizes free tissue transfer to the site of the tissue defects after mastectomy. Next slide. So with all these reconstructive options, it's actually been shown that desire to avoid additional surgery can actually preclude patients from choosing reconstruction after mastectomy. And nipple and skin sparing mastectomy has actually actualized the practice of direct to implant reconstruction. And there exists very few current studies outlining rates of reoperation after breast reconstruction, specifically direct to implant. Next slide. So the purpose of our study was to characterize reoperations after direct implant breast reconstruction and compare these outcomes to tissue expander and autologous free flap reconstruction. Next slide. So we conducted a retrospective 10-year review of all patients undergoing mastectomy with reconstruction at our institution. Next. And we characterized their index procedures into implant-based and autologous-based reconstruction. Next. And we characterize reoperations following this index procedure into both planned and unplanned procedures based on the operative indication. Next. So for the purpose of our study, planned procedures included expander exchange to permanent implant prosthesis, as well as nipple grafting and tattooing. And unplanned procedures were procedures resulting from postoperative complications or elective cosmetic revisions. Next. So we had a total of 544 patients with a mean age of 51 years, and this was a relatively healthy cohort with only 13 diabetics and 21 active smokers, and we had 4 years median follow-up. Next. 22% underwent neoadjuvant chemotherapy, with 24% getting adjuvant chemotherapy, and 20% underwent adjuvant radiation therapy. Next line. 56% underwent nipple sparing mastectomy, whereas 39% underwent skin sparing mastectomy. Next. Majority of our patients in terms of reconstruction had direct implant reconstruction, with 32% getting tissue expander and 14% getting autologous free flap reconstruction. Next. So looking at the reoperations data here, we have total reoperations on average. Next. And for the entire cohort, we had an average of 1.6 reoperations. Next. And then next. Whereas the direct to implant cohort had an average of 1.1 operations on average. Sorry, can you go back for the full table, please? So this is the reoperations per patient when comparing direct implant to tissue expander and autologous tissue reconstruction. Next. And so when we're looking at the overall rate of reoperations per patient, only 27% of patients ended up having no subsequent reoperations. Next. Whereas when you combine those patients getting 0 to 1, it ended up being a majority of patients for the whole cohort. Next. When comparing single stage reconstruction, next, we saw that a significant frequency of patients, 45% in the direct implant group, actually ended up having no subsequent surgeries, whereas 24% in the autologous group ended up having no subsequent surgeries. Next. Next. And then when we look at the frequency of patients getting 2 or more subsequent reoperations, next, and we combine the percentages in these figures, next, we see that 29% of direct implant patients went on to have 2 or more subsequent reoperations. Next. And if we look at the reverse of that, patients getting 0 to 1 operations in the direct implant cohort, a majority of patients only ended up requiring about 1 or more procedures, or 1 procedure or less. Next. When looking at planned reoperations, you may notice that, well, if it's a tissue expander cohort, then why didn't they all get, exchanges? Well, if you look at this group, next, 21 patients total ended up having unplanned tissue expander removal due to postoperative complications, and 3 patients actually changed reconstructive modality and went to autologous because they didn't like the results. Next. I'm looking at unplanned reoperations. Next. There was no significant difference in unplanned reoperations overall or unplanned cosmetic revisions between reconstructive modalities. Next. And when we looked at unplanned reoperations overall due to complications, next, the direct implant group had the lowest frequency of unplanned reoperations due to complications. Next. Whereas the autologous group had the highest frequency of unplanned reoperations due to complications. Next. Next. And if we look at our multivariable analysis, active smoking and radiation therapy increased the risk of undergoing 1 or more unplanned reoperations due to complications. Next. When comparing reconstructive types, direct implant versus tissue expander, the direct implant cohort showed a lower risk of undergoing 2 or more total reoperations. That normalizes for the planned exchange to permanent prosthesis that tissue expander patients undergo. Next. And then comparing autologous to direct implant, there were no significant differences in risk of 2 or more total reoperations. Next. Next. Limitations include our retrospective approach from a single institution amongst a healthy cohort of patients and a relatively small in proportion number of autologous patients. Next. So in conclusion, compared to tissue expander, direct implant patients have decreased risk of undergoing 2 or more total reoperations. Next. Compared to autologous free flaps, direct implant patients showed a lower total reoperations on average and a lower rate of unplanned reoperations. Next. So overall, even though our outcomes are pretty good, a majority of direct implant patients can expect to complete at least one additional procedure following reconstruction. Next. So regardless of reconstructive modality, a majority of patients undergo additional surgery. The impact of this on quality of life warrants further investigation. So overall, after direct implant patients, after direct implant reconstruction, patient outcomes are seldom one and done. Thank you.
Thank you. Very nice talk. This paper is being discussed by Dr. Santa Maria from the University of Nebraska Medical Center.
Congratulations, Dr. Hamlin, for this excellent paper and presentation. I commend you. Your paper provides insight into what we all already know, that indeed direct to implant recon is seldom one and done. It is sold like that many times to patients. About 55% of patients of your cohort that underwent direct to implant underwent additional operations. Your data also suggests that direct to implant had the lowest rates of reoperations and complications. I want to point out, again, you pointed out as a limitation, the relatively healthy cohort of your patients. We're an average BMI of 25.7 and the average BMI for the direct to implant of 24.8. Not exactly the BMI representative of many of our practices, in which higher BMIs and exist, thus a lower chance of doing nipple sparing, and an actually higher chance of us, for example, in our practice to offer autologous reconstructions more often, because it's attractive to some patients still to not have implants and have their own tissue. So I have 3 questions. My first question from these data is to bring it home. How would you counsel patients and advise them about direct to implant reconstruction, a potential for need for more operations when compared to other techniques? So in your daily practice, how would you advise your patients?
Yeah, it's a great question. When counseling a patient regarding what kind of modality they could pursue if they were interested in direct implant, I would really kind of cite this data, especially at our institution. So I'd say there'd be a decreased risk of subsequent reoperations compared to an autologous approach. I also do want to acknowledge that there could be kind of a self-selection bias, or not self-selection, but maybe a selection bias in terms of patients getting direct implant versus tissue expander reconstruction in terms of ptosis, skin quality, things such as that nature. So if I was counseling a patient on that, I would cite a lot of the data that we have in the paper currently.
Okay. My second question is that 54% of your patients, so a total of 294 patients, underwent direct to implant reconstruction. This appears to be very high ratio proportion of your patients undergoing direct to implant. It, as you mentioned, could be somewhat of the selection bias, but what would be the selection criteria in your institution? What is your ideal perfect candidate for a direct to implant?
Perfect candidate would be, well, someone who would want to undergo direct implant or implant-based reconstruction, one, but also someone with, like I said, good skin quality, no significant degree of ptosis, as well as someone who may be less likely to require adjuvant therapies. However, I wouldn't only offer direct implant to just those patients, but just theoretically speaking, that would likely be a more ideal candidate.
All right. And my last question is 70% of your direct to implant patients underwent subpectoral implants and 30% underwent prepectoral implants in the direct to implant group. Is this common practice to favor subpectoral implants in your institution, or this could represent a trend over time and more recently more prepectoral implants are being performed? And were there any differences in reoperation or outcomes between subpectoral or prepectoral direct to implant patients?
It's a great question. There was no difference in terms of prepectoral and subpectoral in terms of subsequent reoperations. Didn't have time to go into it in the talk, but in the paper, we kind of go into that briefly. And that was a very astute observation in terms of trends over time. We have the amount of prepectoral and subpectoral has changed based on the number of operations by a number of our plastic surgery consultants at our institution. So it has kind of varied with time, but not necessarily with patient-specific factors.
Yeah, I think we can take a quick question.
Tom White, Salt Lake City. That was a really nice presentation, but I never heard you mention the word cancer once in this talk.
Mhm.
And I'm just, I want you to convince me that you know when you're going to do a direct to implant that your oncologic needs are being met and that you haven't, do you ever have to revise an operation or do something different because of something you find out on pathology 2 days later?
We're actually very fortunate at our institution. We have pathologists who perform intraoperative assessments of our specimens. So our rate of returning patients to the operating room for subsequent margin excisions relatively really low. You know, I won't speak as to the numerous literature that outlines the oncologic safety of reconstruction, but I will say that you know, we're very fortunate at our institution for the pathologists that we have that really make it. We rely on them heavily to tell us if our margins are good. For the sake of this paper, 73% of the patients in our cohort had invasive cancer as opposed to 24% or so had DCIS.
Hi, Stephanie Niemer, Texas Tech, El Paso. I had two questions for you. One was in your institution, what are your radiation oncologists' feelings about radiating after a direct to implant reconstruction? You
That's
can
a
answer
great-
that one and I'll ask you.
No, that's a great question. I personally haven't asked them what their thoughts are, but kind of as a derivative of that, I know that the radiation that they practice really does. It's very specific and it's very targeted therapy. It's not quite the big, broad, you know, treatment zone that you may get at some places. But I actually haven't asked specifically our radiation oncologists what their thoughts are.
Sure. The other question that I had was, and I may have missed it, but can you give me an idea of the size of implants or the range of size of implants that you're putting in direct to implant reconstructions?
Sure. It will vary significantly based on the, you know, the patient's body habitus as well as kind of their reconstructive preference in terms they want to be smaller, bigger, same size. Couldn't really throw out any specific numbers, but I would say anywhere between like 100 to maybe like 300 cc's.
Okay, so on the smaller end, just for the non-plastic surgeons in the room, the implants go up to about 800. And I would be very, very hesitant to put a large implant underneath the mastectomy flap and be like, hey, you just lost all your blood supply, but hold this giant implant up.
Yep.
And so I do think that's an important thing. And I hope that in your paper, you'll address that because there's the selection for who is eligible or appropriate for direct implant. I think you do have to keep that in mind.
Very good point. Thank you.
Thank you very much. Very nice
Thank you, Dr.
presentation.
Hammond. Thank you for prevailing. All right. Next, we should be having that should be commonly performed pelvic binder modifications for femoral access may hinder binder efficacy. And we have Dr. Maren Chavez from St. Joseph's Hospital and Medical Center. And I understand that you have.
I have a clicker now,
have a
so
clicker. All
thank you,
right.
because this may have been painful if I
Fancy.
didn't. Thank you for that introduction. I appreciate it. I have no disclosures. I wanted to start this presentation just with a quick story. It was a very terrible day in our thoracic surgery service, and at that time, the fellow turned to me and she said, Marin, everyone in this hospital is trying to kill your patient. It's just whether they're a ninja or an assassin, you either see the kill coming or you don't. And I thought this was actually very applicable to this talk. I loved the analogy and I thought I can apply this to trauma injuries in my head too. So when I think about trauma injuries, I kind of think about them in two different categories. You have your ninja injuries, and these are the injuries that they're the crowd pleasers. You see them coming from a mile away, you know, very Kill Bill style, gunshot wounds, stabbings, traumatic head and big head injuries. And then you have your assassin injuries, and those are the ones that kind of sneak up on you. You know, they may be overshadowed in the trauma bay by other things that are going on. And, you know, they may cause problems later on that you don't realize right away. And that's small head bleeds, blunt cerebrovascular injuries, and then pelvic fractures, which we're here to talk about today. And so why do we care about pelvic fractures in the trauma setting? And it's really because they have a very high mortality when patients present hemodynamically unstable. The literature will quote anywhere from 20 to 50% mortality if a patient's unstable in the trauma bay. And really, this is multifactorial. So you have this multidimensional bleeding. This isn't just a gunshot wound to an artery. This is venous bleeding, it's arterial bleeding, it can be bone bleeding. And then this is an area that's very difficult for us to access surgically. So oftentimes we have to get our orthopedic colleagues or interventional radiology involved to help us with this. And in order to disrupt the pelvic ring, it requires a very high velocity injury. So these are often associated with other injuries that are going to need to be attended to as well. And finally, there's no real consensus on the optimal management. A lot of times in trauma, we have very cut and dry rules of go to the operating room if the patient's unstable. But with a pelvic fracture, do you resuscitate them and bring them to the IR suite? Do you pre-peritoneal pack? Do you have orthopedics put an external fixator? So there's more options here, which blurs the picture as well. So per the ATLS guidelines, they recommend placing a pelvic circumferential compression device in patients that are hemodynamically unstable with an open book pelvic fracture when they present. And really, this is a twofold reason. So you want to reduce the potential space of the pelvis, and you also want to create that tamponade effect. But the problem is what happens when this doesn't work? And we've come up with other adjuncts that help in this scenario when a patient has continued hemorrhage or remains hemodynamically unstable. And those are things like angioembolization, pre-peritoneal packing, external fixation, as well as Roboa devices. So there's something that all of these things have in common, and that is when you place a pelvic binder, all of the important anatomy that you need to be able to do this procedure is completely obscured by the pelvic binder. So here you see a schematic of a properly placed pelvic binder, which is over the greater trochanter. And then on the right side of the screen, you can see a very nice angiogram image that includes the pelvis as well as the iliac and femoral vasculature. And there's a couple anatomical marks that I want to point out. So here you can see the ASIS as well as the pubic symphysis and the inguinal ligament at its insertion sites, as well as the greater trochanter. I've marked here about where you would want to make your femoral access, so below the inguinal ligament and above the bifurcation, as well as about where you would make a fan and steel incision in order to pre-peritoneal pack about 2 to 3 centimeters above the pubic symphysis. And then you put on a pelvic binder, and that's all completely obscured. So all of those access points that you would need are completely covered by this pelvic binder. So as surgeons, we have ingenuity, we're crafty. So we worked with what we had and we modified these binders in order to make them work for the current procedures that we're doing for hemorrhage and pelvic fractures. And there's 2 specific modifications that are described in the literature. One by Dr. Brenner and Dr. Moore in their Roboa series, where they talk about moving the pelvic binder cranially as well as cutting out a triangle to allow for access to the femoral vasculature. And you can see that in the picture here, as well as the Roboa device inserted. Additionally, Dr. Gardner described taping or binding the thighs as well as internally rotating the lower extremities in order to allow for some compression of that area as well. So our question was, do these described modifications that allow for femoral access decrease the efficacy of the pelvic binders and their ability to reduce fractures? Here is a cadaver from our study, and you can see that we've traced out about where the inguinal ligament as well as the femoral vasculature would be in this patient. How we did this, we took 4 fresh cadavers and 3 commercially available pelvic binders. So the pelvic binder, the slam sling, and the T-pod, and we created open book fractures in these cadavers. And then we did 3 trials. So we had the PCCD properly placed, we moved it caudal, and then we moved it cranially and cut out that triangle. And then we compared the caudal and the cranial movement to the properly placed pelvic binder. So first we'll talk about when we moved it caudal. These are our results. So you can see that 100% of the time when the pelvic compression device was properly placed, it reduced the fracture. And we defined an adequate reduction as less than 1 centimeter of diastasis of the pubic symphysis. And then when we moved the pelvic circumferential compression device caudal, you can see that the percent of times that it was able to adequately reduce the fracture to less than 1 centimeter significantly reduced, most dramatically with the T-pod at 29%. And when we compared proper placement to the caudal movement, there was a statistically significant difference between all three of these binders. Next, we moved it cranially and then cut out that area for the femoral triangle. And you can see again, when the pelvic circumferential compression device was properly placed, it reduced the fracture 100% of the time to less than 1 centimeter. And then when it was modified, moved cranially and cut, it was 85 and 92% respectively for the pelvic binder and the T-pod. This was not statistically significant. You will notice that the SAM sling was not included in this because of the way that that pelvic binder is made. If you cut it, the device integrity is completely ruined, so you can't actually use it here. Here's a graphic representation of that as well. So 100% of the time on the left hand of the screen with correct placement. And then you can see pretty dramatically when moved caudal that percent of fracture reduction goes down. And again, with the modified, moving it cranially and being cut, also reduced, but not as dramatic as the caudal movement of the pelvic binder. So some conclusions that we drew from this study: this does provide a framework for trauma surgeons to manage pelvic fractures that may require additional procedures. Additionally, we did see that both cranial and caudal movement can provide fracture reduction, but both at different costs. So they have differing success rates, which we've shown. Additionally, they have different surgical implications. So if you move the pelvic binder cranially, you're not going to be able to do an exploratory laparotomy or preperitoneal pack with it in place. And then if you were to move it caudally, they have other long bone fractures of the extremities that could represent a potential issue. So what is the significance of this, and why did you just listen to me talk about pelvic fractures for the last 5 minutes? And really, to understand this, we'd have to go back to our 8th grade geometry. And we estimate the pelvis as basically the volume of a sphere, which is 4/3 pi r cubed. And if you say an adult pelvis is about 12 centimeters in diameter and you calculate the volume of a pelvis, that's about 900 cc's. And if you increase that by even 1 centimeter, accounting for the fact that the diastasis is still there and the pelvic fracture was not reduced, that volume increases to almost 1500 cc's. So a 600 cc difference, which is about 2 units of blood, which is probably not insignificant in a bleeding trauma patient. So I think the area of future research can really tell, does this translate clinically? Are these patients remaining hemodynamically unstable longer? Are they requiring more blood products? And in addition to that, I think it gives us an opportunity to reevaluate. Could we make a new pelvic binder that's more applicable to the 21st century when we're doing all of these procedures? And that's all I have. Thank you. This is our chief class this year, where 7 of 8 of us are ladies. So everyone watch out. Thank you.
All right. Thank you very much, Dr. Chavez. The paper will be discussed by Dr. White.
Good afternoon, and thank you so much for the invitation and the provision of the manuscript in a timely way. And I really enjoyed your style of presentation. It was refreshing and captivating and all those things. And congratulations. 2 things. Number one, you didn't include the bed sheet in your analysis, and I'm just curious as to why. Obviously, it was a conscious decision not to study that one as well, alongside with the commercially available devices. It's still taught in ATLS. It's still probably the most widely used pelvic retention or compression device utilized, certainly worldwide and maybe still in the United States. So please explain your rationale for not including that in your testing. Oh, yeah, you can do it
sorry,
now.
go ahead. No, sorry, go ahead.
And then secondly, well, I only have 11 questions, so we might want to just, actually, I just have 2. But go ahead, answer that one and then
I think that, our thinking on that was, probably in the pre-hospital setting a lot more, they're using sheets and that as such to, reduce these fractures. But in most, large institutions, they're going to have, what we looked at is there's availability of these pelvic binders, and that's typically what's being used. And that's what, usually we're using as surgeons, which moving forward in order to do these other procedures that we need to do. But yeah, that's absolutely a great point that we could have included the sheet as well.
Yeah. Well, the literature suggests that maybe the sheet's not as effective as these devices, but it's still widely used and might be a nice addition to that analysis. The second question and the final one is, obviously, as you were conducting the study, it's elegant in its simplicity, and the results are certainly not surprising. I was delighted to hear that the compression devices worked 100% of the time as directed, and it's not surprising that the modifications didn't work quite as well. But you must be thinking about, you alluded to the fact that maybe we need to design a better mousetrap. And do we really need to wait for further studies or clinical validation of these findings? Shouldn't we just be inventing a better mousetrap? And you must have some ideas on how that can be done. It can't be that challenging to develop a device that exposes the suprapubic abdomen and or the femoral artery. So at the risk of disclosing or jeopardizing your future intellectual property advantages, would you just give us an idea or two about how you thought maybe a new device could be designed?
Yes, I think
Thank you.
definitely think that there's more to come in that arena. And I hope that it's my passive income one day if I was able to help create a new pelvic binder. But I definitely think there's potential. We've discussed with some of my attendings who were fantastic and helped me with this study, did probably more than I did. But I think that I don't want to give away anyone else's ideas on how to do this, but I think that we've seen that there's ways that we can do this effectively without really obscuring that area and still achieving that tamponade and the reduction of the pelvic space. And really, it's just going to involve some really great engineers in order to help us with that.
Any questions from the floor? I did have a question, and before you go away,
Yeah, absolutely.
how many cadavers did you study? And can you tell us a little bit about your mechanism of injury, as it were?
Yes. So we had 4 cadavers in our study, 3 male cadavers and 1 female cadaver. Of course, we would like more. Our institution is actually under the name of Creighton now. So we're hoping with kind of the, addition of an academic setting, we may be able to get some more cadavers in the future. And how we did that is we used an osteotome to create the fracture. And then we used a Finichetto retractor to actually create a diastasis of about 10 centimeters. And we were hoping with that, that large diastasis that we could account for any like recoil or any, tissue laxity that would happen with the repeated use of the binder.
Okay. Yeah, one disadvantage of that mechanism as opposed to a patient who's actually had an injury is that often with the mechanism of injury, you've also got disruption of all the muscular support. But it was a great, it was a good model, and thank you very much for a great presentation.
Thank you. I appreciate it.
Next paper is comparing outcomes of cholecystectomies in white versus minority patients. It's being presented by Olivia Tsai from University of California in Irvine.
Thank you. Good afternoon. Thank you for giving us the opportunity to present here today. My name is Olivia Tsai. I am currently a first-year resident at the University of Arizona in Phoenix. Today, I'll be sharing this project that I did during my time as a medical student at the University of California, Irvine.
Should be, yep.
Okay. So first off, we have no disclosures. Cholecystectomies are commonly performed. It is estimated that about 700,000 cholecystectomies are performed a year, that about 20 million Americans have gallstones. And in a retrospective study, looking at the past 3 decades, we found that cholecystectomies cost about $6.2 billion in annual expenditure. And because they are common, and because anyone with a gallbladder can have gallstones, cholecystectomies are commonly used to examine the surgical outcomes in different patient populations. And so similarly, we use cholecystectomies as a way for us to understand the disparity that exists between white and minority patients, both during their presentation to the hospital, as well as the clinical outcomes after they receive their surgery. We also wanted to look at the factors that contributed to this disparity. And we looked at insurance status as a proxy for healthcare access to understand how that plays a role in the bigger picture of disparity. So this was a retrospective single center analysis. We looked at 1,539 patients who underwent cholecystectomies at the UC Irvine Medical Center between July 2013 and October 2018. For these patients, we looked into their charts to understand more about their demographics, as well as information related to the procedure itself, including their insurance status, their admission status, and complications, as well as length of stay. Before I go on, there are a few definitions that I wanted to clarify. When we talk about minority, for the purposes of our study, that was anyone who was considered non-white, Hispanic, Asian, Black, Pacific Islander, Native Hawaiian. The definition that we used for uninsured, when we looked at the insurance categories, were any patient who came in with no insurance at all, patients who paid completely out of pocket for their healthcare, and then patients who were issued emergency insurance, also known as emergency Medi-Cal in the state of California. So looking at our results, for the patient population we had, there was about 37% of patients who were white and 63% who qualified as minority. And consistent with the overall gallbladder population, the majority of the patients were female. From our study, we found that the minority patients presented at a much younger age compared to their white counterparts at 45.5 as opposed to 54. We also found that minority patients were more likely to present to the hospital as an emergent admission compared to their white counterparts at 76% compared to 68. When they were actually in the hospital and admitted to receive their surgery, there was actually no significant difference in the clinical outcomes of these patients. And this was intra and postoperative complications, length of stay, ICU stay, and disposition. Going on to insurance, we found that whites were more commonly insured and that they fell under the category of commercial, contract, and private insurance. On the other hand, minority patients were more commonly uninsured, and they fell into the category of self-pay, none, or emergency Medi-Cal. For the evaluation of the financial burden of the cholecystectomy, we looked at charge as a marker. Surprisingly, we found that the uninsured actually had an overall lower charge compared to the insured patients. However, if we just look at the uninsured group, comparing patients who were self-pay or no insurance versus patients who received that emergency Medi-Cal, those who received any kind of insurance assistance tended to fare better, albeit not significantly, than those who had nothing at all. So there are a few limitations that we wanted to bring up in our study, one of which is the number of subjects. This was a study done over 5 years at a single academic center. And so we believe that if we did expand that time span and we did expand the location from single to multi-center, we could have better insight into this matter. The second is the topic of cost versus charge. I had mentioned before that we looked at charge as a marker for financial burden. However, charge is something that can fluctuate depending on the type of insurance as well as the comorbidities of a patient. A patient who has private insurance can be charged higher under the assumption that a private insurance will not pay 100% of the bill. Similarly, a patient who has Medicare qualifies for Medicare because they are over the age of 65, they have significant comorbidities or are disabled. And so inevitably, these patients will have a higher charge, not related to their gallbladder per se, but related to the overall care that they need to receive in the hospital. And so taking that into consideration, there is the fact that charge may not be the best marker for financial burden as opposed to something like cost, which looks specifically at the service that was provided. And this is also something that we as a team are actively looking into to obtain and to further investigate. Finally, we think it would be very beneficial to understand how many previous visits a patient has had before they finally came to the hospital for surgery. However, there is a limitation because it's difficult to find out exactly how many visits a patient has had. It is only as accurate as the documentation and as accurate as the history that the patient provides you. So in conclusion, minority patients are more likely to present at a younger age and require emergent surgery. However, once they are in the hospital, there is no significant difference in the clinical outcomes. Minorities are more likely to be uninsured, and although uninsured patients have an overall higher charge, those who are uninsured but receive some sort of emergent insurance and some sort of insurance fare better financially than those who have none at all. And so disparities exist, and it's not because we provide a different quality of care for patients based on their insurance status or because they are a minority, but because there are factors that build up until the day they present to the hospital. And so I hope, and it is our hope, that with this study, we can bring up the discussion, if not continue it, of what we can do for patients before they present, before they need surgery, and before they're on our table. And this could include anything from preventative care to education, because this in reality is where the disparity begins. Thank you.
This paper is being discussed by Dr. Ann Mancino.
Thank you very much. I'd like to thank Southwestern for the opportunity to review this talk, and I want to congratulate you on a very well organized and presented talk. And also thank you for getting your paper to me in a timely fashion. I have a couple of questions for you. One, and this is just because I have a brother who does a lot with demographics, and he asked me this question, but you do have patients who, when you're looking at demographics, identify as white with Hispanic or Latino origin. And I was just curious, in your dividing out of patients, where did those patients fall? Did you put them under white or did you put them under minorities? And then the other question was, you hypothesized that they were uninsured, the minorities, which they were, but you also thought that they would have more complications and they did not. When I was looking at this, I just wondered, did you actually look specifically at uninsured patients to see if they had more complications? And also maybe look at the patients who had emergency surgeries and then see if there were any common factors among those. Because you did have in your white patients a significant amount of more people who were on Medicare, and we've been hearing all about geriatric problems in surgery all day, and I realized I'm one of them now. And so I wondered if maybe some of the patients who had emergency surgery that were white were older, had other comorbidities, and maybe that's why you didn't see a significant amount of worse outcomes in your younger minority patients.
Yeah, thank you very much. I appreciate your review of my paper. And to answer your question, the first being the race categories. So when we were looking at the data, there was no category for anyone who was interracial. It was either they were white or they were Hispanic, and it was based on what they had provided the hospital on admission. That said, I think this brings up a very good discussion point because there are increasingly a larger number of Americans who identify as multiracial. Even in the most recent census in 2020, we found that there were more people who identified in America as multiracial compared to years prior. And so I think this is definitely something that could blur the lines between someone who is white versus minority. And I think this is something that we should definitely look into as a future direction. To answer your second question about insured versus uninsured, and looking at complications. So in the initial data, which was not included in the presentation, we had done an odds ratio analysis of insured versus uninsured in terms of postoperative and intraoperative complications. And similar to what we have found, there was no significant difference. And for us, that reinforces what we are thinking, that this is not so much a matter of post-hospitalization, what is going on in the hospital, what are we doing differently? It's more so that this is something that happens before they even come into the hospital. And in regards to your point of looking at patients who have complications and seeing if there is a significant difference or something that's similar between patients who have had complications versus those who have not, I think that's an excellent point that we can definitely look into further. For the investigation, we were mostly focusing on minority versus white patients. We were looking at insurance, but I think it's important to look from a different direction and from a different perspective to see what exactly is causing that difference. So I appreciate that.
Thank you.
Very nice. Olivia, very nice presentation. Were you able to look if the minority patients had symptoms for a longer time before they present, or maybe they had multiple episodes in the past, but they were avoiding to go to the hospital? Were you able to look that type of data from the?
Yeah, so
Review?
this was something that we had looked at in terms of when we were chart checking for the patients. We did search to see if there was any documentation of a previous visit. And again, similar to what I've looked at, is that it is only as reliable as what the patient tells you and what is
Yeah.
documented. So I agree, and that is definitely something we are looking towards. And we think one of the reasons we even came up with the study is thinking that there are so many minority patients who are putting off coming to a doctor or coming to healthcare because they don't have the means or because they don't have the access to healthcare. And so I think this is a very important point and something that should be looked at. But unfortunately, because of the way that this data is collected or recorded, it is a little difficult to have an objective view of it.
Okay, thank you very much.
Thank
There's a
you.
question from the floor.
No, there is one, sorry.
If
Yes,
we have
go ahead.
time. It's a little bit more of a comment. Morgan Bonds from the University of Oklahoma.
I think when we are looking at people, looking at demographics or disparities, it's important to keep in mind that Hispanic is not a race. People who are Black identify as Hispanic, people who are white identify as Hispanic. So sometimes you just have to make that a different category completely. And the second thing is, as you said, this was a single center study and you didn't find many differences in complications, but complications from gallbladder surgery are pretty rare. So you need significant power, I think, to find any of those. So your idea about a multi-institutional study would be warranted, I think.
Okay, thank you.
Thank you.
For our next paper, I'd like to see somebody, yeah, I was gonna say, somebody should be moving towards the microphone. If not, I guess we could present it ourselves, but
We have somebody.
yeah, we do. No, I see you coming. So we're talking about development of a novel tool to predict pulmonary complications in trauma patients with and without chest injury. Pardon me. Dr. Lee from the University of Southern California.
Yeah, I'm actually a medical student.
I'm sorry. Okay.
Yeah, so good afternoon,
Mr. Lee.
everybody. My name is Rubel Lee. I'm a third-year medical student at the University of Southern California. And I'm here to present a development of a new tool to predict pulmonary complications in trauma patients. So I have no disclosures. So as I'm sure everyone's aware here, chest trauma is a very serious event. It accounts for 10 to 15% of all trauma cases and 20 to 25% of deaths in polytrauma patients. But it's not just the trauma itself that puts patient at risk, but also the pulmonary complications that follow after. And those may be as high as 49%. So it makes sense then that a lot of tools that can assess patient at risk have been developed. So these include the pulmonary contusion score, the Wagner score, thoracic trauma severity score, and many more. And all of these tools assess pulmonary complication risk for patients with chest trauma. And that makes a lot of sense anatomically speaking, but the literature review shows it's not just the chest trauma patients, but all trauma patients that are an increased risk of developing pulmonary complications. And currently there's no simple tool out there that can be applicable and used for the general trauma population. So we set out to develop one, and we had the hypothesis that extrathoracic injury variables would also actually increase the risk of developing pulmonary complications. So we did a retrospective analysis of the 2017 Trauma Quality Improvement Program and included patients that were 18 years and older. So they gave us a study population of around 600,000 patients, and we took half of them to train and derive our model on, and the other half we used to validate our results. So how was the model actually created? So we performed a literature review and identified potential predictors of pulmonary complications. And then we used those variables, put them into multiple stepwise logistic regression models that removed variables that were not independently associated with our dependent variable, which was pulmonary complications, which for the sake of this study, we defined as either PE, ARDS, unplanned intubation, or pneumonia. So once we identified our predictors, we then created a scoring system by taking the odds ratio of each variable and dividing it by the lowest common denominator. And finally, we validate our results using area under the curve analysis. So this is what came out. We had a total of 22 variables that kind of fell into three broader categorical buckets, which were demographics, comorbidities, and injury variables, as we hypothesized. And the score ranged from 0 to 43 and had an area under the curve of 0.8. And we called it the trauma-induced pulmonary event score, in short, TP score. So as a group, injury was the most predominant predictor of pulmonary complications. It accounted for 74% of the total score. And it also included the two strongest single predictors of pulmonary complications, which was injury to the spinal cord and then injury to the bile duct. The second group that we also had were comorbidities, which accounted for 21% of the total score. And finally, demographics, which accounted for 5% of the total score. So as I mentioned previously, we took half of our population to validate our results. And when we ran our model with this validation cohort, our area under the curve was 0.79, which is very close to the 0.8 that we got. We also need to ensure that the two cohorts that we compared, mainly derivation, validation, were similar. So I have a bunch of tables here, and it's a lot, but the main takeaway is that none of these pig values are significant and the two populations were similar. And the only exception was ventilator-associated pneumonia, where we did see a significant difference between the two populations, but there was no difference in our dependent variable. So back to the score itself, and the question is, well, how do you actually use it clinically, which is what's most important? So it's actually quite simple. All you have to do is add up the individual scores to come up with a total score. And then as this graph shows, as the total score increases, the percentage chance of developing pulmonary complication also increases. So I want to go through a quick example. So let's say we have a 67-year-old male, he has a history of diabetes, presents to the ED following MBC, and is found to have a splenic lac on CT. So by virtue of him being older than 67 and being male, he gets 2 points. He has diabetes, that's 1 point, and then splenic injury, that's 2 points, for a total of 5 points. So if you looked at it on the graph, that puts him around a 2.5% chance of developing pulmonary complications. So given the fact that most of our variables were related to injury, it makes sense that this tool will be most relevant for patients that have had a PAN scan done on them. And a potential application of this tool is for trauma centers to develop protocols that identify specific cutoff values for pulmonary complication risk that would warrant specific interventions like ICU disposition, continuous pulse ox monitoring, or ABG. So as with all database analyses, there's a chance for reporting errors, coding errors, missing data. Certain pertinent parameters may not be part of the database. And then we did see a significant difference in our ventilator-associated pneumonia variable. And then finally, the database that we use only captures index hospitalizations, but there's a chance that pulmonary complications could occur post-discharge. So in conclusion, the TPA score is a novel tool that predicts pulmonary complications in all trauma patients, not just chest trauma patients. An increased score is associated with an increased chance of developing pulmonary complications. And this tool could be useful for physicians to make informed decisions with regards to monitoring and disposition of patients. And finally, I want to thank Dr. Goring, Dr. Kuza, Dr. Namias, and Nalba for their contribution.
Thank you. Dr. Fred Parachi, who was the invited discussant, is not able to be with us today, but he has sent in his questions and discussion. So the authors have queried the TQIP database to create derivation and validation cohorts to develop a tool to predict pulmonary complications among hospitalized trauma patients. The discriminative ability of the score was good, with an area under the curve of 0.8. He commends the authors on a very methodologically, statistically sound manuscript. Predictive tools, particularly in the information technology age, can be a powerful adjunct to inform clinical judgment, as well as conversations with patients' loved ones. Sorry. He had the following questions. Your score ranges from 0 to 43. Are you able to provide the descriptive statistics of the score among both your derivation and validation cohorts? That is the range, the median, and standard deviation. Was the score distributed normally? Also, one marker of a good score is that there's variability among the sample, such that some people have very low scores and some very high scores, but that all scores are represented.
Yeah, so thank you for this very interesting question. Unfortunately, Dr. Piaggi won't be with us today. So one of the challenges that comes with coming up with a scoring tool is to make sure that the set of data that you have available is readily available and has a decent ROC and is also practical to use and integer in value. And another kind of checkpoint, as you mentioned, is for the scoring system to be normally distributed. And unfortunately, this was not the case in our scoring system. So for both the validation and derivation set, our standard deviation and median was 3. So most of our scores fell at the lower end of the table. And we think this may be due to inherent limitations of the database that we used itself, where we had potentially coders only capture admissions data for polytrauma patients. So our scoring system will definitely need further validation, either through a prospective study or a single center retrospective study that has more granular patient information data.
Okay, I'm going to give you 2 more questions from Dr. Karachi. Can you flip back to the outcomes figure? And his question was,
I
are
don't
you able
think
to go
it's-
back? Oh, we're loaded again. Okay, let's, if we can back up to that. He said, notices that the outcomes figure stops at a score of 15, although your maximal score was 43. Does the score stop being associated with increased likelihood of pulmonary complications at values between 15 and 43? Or there are just not enough patients who were high enough to score in the sample?
Yeah, so kind of going along with the first question, we have very few patients that scored above a 15. And again, we think this may be due to poor documentation within our database itself, where coders would not put in more data for polytrauma patients.
And the final question is, one of your goals was to create a complication score that works in patients with and without chest wall injury. Were you able at all to look to differentiate between those groups and to see if the area under the curve for the type score is different between the groups? You may not have done this analysis, I don't know.
Yeah, so that's actually a very good suggestion, and it could be something that we may include in our manuscript actually and enhance it. So we did divide our patient population into those that had no thoracic injury, and that was defined by AIS score of thorax of 0. And in that case, our AOC for the TPA score was 0.75. And then when we looked at patients that had a thoracic injury, which was defined by AIS thorax of 1 or greater, our area under curve was 0.77.
Very good. I believe I see a question from the floor.
Shrepple, Colorado Springs. These scores are always very interesting to hear about at meetings, but how do you actually use it clinically? If there's a patient that actually looks really good but has a high TP score, do you really put them in the ICU and use a bed when they may not need it? And the second question is, do you really calculate the score currently on all your patients? So if I were to look at your records, do you have a TP score on your charts?
Yeah, so right now, this is more of like a beginning study because a lot of the variables that we have here is just the idea that extrathoracic injury variables and not just chest trauma itself could cause pulmonary complications. So it's not something that I would use currently in a hospital setting right now. And as I mentioned, it will need to be further validated either through a prospective study or a retrospective study of more granular patient information, because we are limited somewhat by the database that we use.
Okay. Other questions? All right. I would say it looks like we've completed our session. Thank you for an excellent presentation. Loud applause.
Very nice.
And we are, thanks to all the presenters. Round of applause for the presenters and the discussants.
Thank you.
And I think you can all give yourselves a break.